this is a mistake that we see very often.
And you say that happens in 30 to 50%. Welcome to the next episode of Endoscopy Essentials. I'm very happy to have one of my first guests, my old friend Jacques Deviere, back.
It's my pleasure.
Jacques, we have a special topic today because when you look back, you have watched a very long and also influenced a very long period of pancreatic endotherapy in chronic pancreatitis for pain. And I learned that the first pancreatic sphincterotomy was done in Brussels at your place.
Yeah, this is true. And it was when I was not a physician. I was still finishing my high school. So in 1976, Michel Kremer did the first pancreatic sphincterotomy for a case which was interesting, which was a pancreatic cholangitis. It was a pancreatic stone which was impacted at the papilla, but it was a white calcium carbonate stones. And then he opened the sphincter, he did a pancreatic sphincterotomy, and he removed the stone. And interestingly, 20 years later, the patient became my patient because he had relapsing stones between the body and tail that at that time we treated by shockwave lithotripsy. So this is probably the longest follow-up for a chronic pancreatitis treatment.
Okay, and we can present it here today. Let's start with the principle. The principle is desobstruction, right? So get rid of the stone, get rid of the obstruction. Looking back, are there patients who benefit more, like those with a rather fresh obstruction, months to years, or?
Yes, I think that at the beginning there were very few indications because of the kind of stone we are dealing with. These calcium carbonate stones, especially in Europe, in US, probably different in India, they are very often deeply impacted into the duct, and they are almost impossible or very difficult to remove by mechanical way. No, we have other possibilities, but at that time, with a guide wire, passing a guide wire, placing a stent was almost impossible. Then the shockwave lithotripsy came, and we had the chance to work in a multidisciplinary unit where the urologists were also working, which made that the shockwave lithotripter, the extracorporeal shockwave lithotripter, I speak about a high-power machine with fluoroscopic control, was available, and we were allowed to use it as gastroenterologists. So in the 80s, in the mid-80s, it completely changed when we realized that we could fragment the stones in millimetric fragment, because with this high-power machine, and unfortunately there are very few GI centers which do that, you can really fragment the stone in 1 or 2 sessions in millimetric fragments. And then the number of indications increase, and as you say, the indication is to decompress the main pancreatic duct. I think that the pain in chronic pancreatitis is not due to the high pressure. There are not barosensors in the duct, but this high pressure in the duct with the lack of compliance of the pancreatic parenchyma induce ischemia, and typically the postprandial pain or the continuous pain. So this is to decompress the duct in order to decrease the parenchymal pressure under stimulation of the pancreas.
Okay, one technical thing, ESWL is not ESWL, right? So you said high power, you even do it under sedation or general anesthesia?
We can do, nowadays we do that under general anesthesia in order to try to fragment the obstructive stone. Of course, to answer your previous question, we focus mainly on patients with big stones in the head or a single obstructive stone, for example, in the body. There are patients with plenty of stone in the secondary branch. Then I think these patients are not candidates for treatment. But those who have an obstructive stone or 2 or 3 obstructive stones can be candidate. And we do that under general anesthesia in order to be allowed to provide enough fragmentation in a single session.
So not every ESWL machine, at least with the settings which are used in orthopedics, is useful, because you have to really apply high power, right?
Yes, one of the mistake is to make the confusion between a high power machine for typically the lithoscope and with fluoroscopic guidance, and the low power machine with ultrasound guidance. The low power machine are very good for your shoulder, for the small calcification, but they are not able to fragment the pancreatic stone. And I remember a discussion that I had with Nipsu Enra, because in Hamburg, in your place, there was somebody doing shockwave lithotripsy with ultrasound guidance, and he was doing 20 or 30 sessions of lithotripsy without getting a real fragmentation. So what is really impressive with the calcium carbonate stone is that the ESWL is much more effective than for common bile duct stone, for example. If you provide shockwave lithotripsy on a common bile duct stone, you will have some big fragment, but there it's really a millimetric fragmentation, and very often you see the small fragments pouring even before doing a sphincterotomy, which brought us to the approach that we have now, is not to do an endoscopy to every patient.
Okay, that's so we have a lot of interesting topics we have to deep dive into. Technically, we understand it's a special ESWL, high power. If you don't have this, don't start. It's a waste of time, right? Yeah. The next is, how is the handling of ERCP? Do you ERCP before ESWL with sphincterotomy, or and then afterwards to clear the duct, or what do you do? I remember your randomized trial years ago.
But at the beginning, we were doing an attempt of ERCP, then a shockwave lithotripsy, then another attempt of ERCP to every patient. And this was the very first report of a large series by Myriam Delay at the end of the 80s. It was in gastro. And then we realized that the best results were obtained when patients were treated early after the onset of pain, when they quit smoking. This was a long-term review that we published in the 90s. And then, because after a shockwave lithotripsy, we were looking at the papilla, we saw the small fragments pouring, and we decided, which was at the opposite of the debate, which was at that time, but it was between surgery, which is even more aggressive, and endotherapy. We decided for those patients who have a single obstructive stone, you know, this big fragment that we see, but which represents a significant number of patients, to provide shockwave lithotripsy and to do an endoscopy only in case of pain relapse. And we did a randomized study comparing this approach as a first step of a shockwave lithotripsy, but again, with a good machine performed by the right person, because it's a dream to think that you sent your patient to the urologist and the urologist will fragment the stone. And this is a mistake that we see very often, in addition to the fact that, unfortunately, there are not so many centers which are equipped with a shockwave lithotripsy in the same environment, but this is a rare disease, so the patient can be referred for shockwave lithotripsy. But what we saw is that by providing shockwave lithotripsy first, we had at 2 years pain relief, which was in more than 55% of the patient, which was similar to the approach combining shockwave lithotripsy and ERCP, and of course we saved money, time of hospitalization, and complication. So no, the approach that we still have after this randomized trial, which was by Jean-Marc Dumonceau in gut in 2003 or 4, we decided to keep this approach, especially for those patients with a single obstructive stone. So if a patient comes to me, I do an MRI, I do a plain CT to see the stone. If the stone is visible on the fluoroscopy, we provide a shockwave lithotripsy. We make sure that we have a very good fragmentation. Sometimes you see a kind of small pancreatography with a small fragment, and then there is a spontaneous elimination of the fragments. And
even without sphincterotomy?
Without sphincterotomy. Okay. Without even, and of course, my first belief that most of these patients have some kind of stenose or stricture, but even of course, we do not take the patient that we call the type 3 with very multiple stenosis in the duct. But those patients who have an homogeneous dilation of the duct and an obstructive stone, even if we think that they may have a small stricture, we start with a shockwave lithotripsy alone. And this approach was not adopted in many places. Partially it was adopted in India, but of course the group of Nagi Reddy, they have 20 times more patients, and of course for their approach is always shockwave lithotripsy and ERCP, but they have also a disease which is slightly different because the stones are a little bit different, they are less impacted, but of course for them they have treated no more than 5,000 patients, I think, and they are doing that. But there is somebody in the unit of endoscopy who does shockwave lithotripsy from the morning to the evening in this patient, and who is specialized in that also with a high power machine.
So good machine, good doctor, and the patient selection is no significant stricture. So the duct should be dilated almost up to the papilla, right?
It should be dilated up to the head, or to be normal in the head and the genu, have an obstructive stone in the body, and then dilated in the body and tail.
But also it only works if the stone is really smashed. So if you break a 1 centimeter stone into several 3 millimeter pieces, it might not work.
It's difficult to say. Sometimes it might work, but as you say, maybe it's psychological. But the best results, the best anatomical results in terms of stone elimination are when we obtain really a millimetric fragmentation of the stone. But very often you have this big stone on the plain film, and after the shockwave lithotripsy, it disappears. It becomes very fade on the image, and this is the patient in whom we have the best result. But we save any intervention in more than half of the patient given this selection.
Yeah. So give it a chance. If it doesn't work clinically, right? So you don't look at CTs and stuff and try to count fragments.
Except if it's in the setting of an evaluation or a clinical trial. But the first evaluation is a clinical. Of course, this patient must have significant pain. I think that at least they should have 2 or 3 attacks of pain every year, or daily pain, or postprandial pain. And then we see them after 6 months or 1 year, or earlier if they have continuous pain, and we evaluate on the clinical standpoint first.
I think that's important to note. Hands off ERCPists first. So do your high quality, high focus, high energy ESWL, and then see. And ERCP only secondarily in the course. And you say that happens in 30 to 50%.
Yes, and then we should evaluate the patient, especially those who have continuous pain, not too late, because we know that whatever the treatment is also true for surgical treatment. Whatever the treatment, except if you remove all the pancreas, which is a very basic approach for the treatment of this disease. But as early you treat the patient, or you do this management of pancreatic ischemia after the onset of pain, the best are the results. And the other factors are mainly the stop of tobacco in your country, even more than the stop of alcohol.
Okay, that's another important message. So now we get to the difficult questions. I think we agree that pain is the main indication. So somebody with, so the classic is the occasional young guy or young girl with a stone, but no pain. And they come because somebody promised them that the function will be improved. What do you say?
Those patients who have a chronic pancreatitis without pain, we do not offer any treatment. We do not offer any treatment, maybe with a very small exception, those patients who have a sudden onset of steatorrhea. For the diabetes, it doesn't change anything. But a sudden onset of steatorrhea with a stone, we may offer a shockwave lithotripsy, but I would not embark the patient in an endoscopic approach with the potential complication, neither in surgical approach for you.
Yes. Another important message. So exocrine insufficiency, if it happens acutely, perhaps, Otherwise not. Endocrine insufficiency, no, right?
At least it's not an indication, and we never saw a significant improvement. We saw a significant improvement of exocrine insufficiency in patients treated by decompression, but never of endocrine insufficiency. But maybe we prevent further endocrine insufficiency.
Yeah, that's why patients come. But I find these discussions very difficult because we don't have evidence, and probably the pancreatitis rate you cause is low in chronic pancreatitis, but it's a difficult balance, isn't it?
No, but this is, at least even today, my clinical advice would be not to touch these patients and not to propose something. Even if they are seeking for something else, but we have to keep in mind also for those who have pain in pancreatitis, that pain is not lasting for life. Pain is a period which can last for 2 to 12 years, according to the very old Swiss of Hamann and Afcobians. And of course, we have to help them to pass this period. But this is why I think that sometimes surgery is an indication in a minority of patients, and I think that the patient should be treated in a medical surgical environment, but going directly to a very invasive surgery which encompasses resection, because those patients who are not candidates for endoscopy are those patients in whom you don't know which kind of surgery to do, because you have stones everywhere. So if you end up with a total pancreatectomy for pancreatitis, this is, in my opinion, still an overtreatment with a few exceptions.
So let's go back to pain. Because some patients have constant pain, that's easy to assess, but some patients have attacks. And if the attacks are not very frequent, like 2 a year, it's difficult to measure success. So you have to wait for a few years. And
as you say, the results which are the most impressive are those in patients with constant pain. And Guido Costamagna also published a series in those patients with what we call a type 4, so that means a distal obstruction with an homogeneous dilation of the duct and constant pain, and there he had results with shockwave lithotripsy combined with endoscopy in more than 90% of cases.
So I think we have identified the ideal candidate: more chronic pain or more frequent pain, a dominant stone in the head, not too many stones, recent onset, etc., etc. At the end of this, we have to discuss about evidence. There's the famous randomized trials saying that surgery is better in a rather limited number of patients, and there's recent evidence also from India that there's some pain improvement, but not so much. Looking back over 30 to 40 years, how would you weigh endotherapy? You are more skeptical in some patients, so it's also a subset. But in comparison to surgery, how do you manage? Because surgeons come and say, this patient has to be operated. Endoscopy is useless.
So I think that the question is to put the patient first and to see and to follow the patient very adequately at the beginning to see if we can relieve pain. One approach was to be less invasive, and I told you that those patients that we define, I will always start to offer a shockwave lithotripsy. The problem is that even if it's a rare disease and 1 center per 10 million inhabitants is enough to treat them, there are very few centers who decide to refer in another place. The surgical approach was proven in randomized trial to be better than the endoscopic approach, but in an environment which was completely different. I remember that for the first randomized trial in Amsterdam, they had no lithotripsy in Amsterdam. And the patients were traveling 200 kilometers to Brussels to get a shockwave lithotripsy in our place and then traveling back. So we were not among the co-author with Myriam Delay because we refused, because there were some things in the trial that we didn't understand in the fact that they removed some patients. We wrote a letter to the New England about that, but we removed us as co-author. But this just shows that this trial comparing two techniques was started by a center which had no experience. They had a very huge experience in endoscopy, but no experience in the specific multidisciplinary management of chronic pancreatitis, including shockwave lithotripsy. So I think that the treatment was not complete for many of them. And of course, the selection of patients was the selection of patients who are referred to surgeon, because this trial and the other one by Issa also in the multicentric Dutch study was patients who were referred to the surgeon. And those patients who are referred to the surgeon, even if the surgeon claimed that as early as possible is better, this is another population that the patient who comes to the gastroenterologist at the very first time. So many of the patients I've seen, because those patients, some of them, I treated them in this randomized control trial, were very advanced chronic pancreatitis with multiple stones and pain lasting for a long period of time.
Okay, so
I was, but I'm still concerned about the fact that if we have a patient with severe pain that we cannot manage very quickly by endoscopy, then we have to discuss with surgeon.
So the concluding message is, I think we identified the ideal patient, and here at least an endoscopic attempt should be made. Then patient referred to surgery, but we also learned that the ideal candidate for endoscopy is probably a better candidate for surgery than the advanced multiple stone case as well.
Then again, this is the question about timing. Another group of patients for whom I'm very enthusiastic for surgery are those patients who have stones or no stones, but most often they have small stone and associated stricture. In these patients, we place stent, even if it's possible, I prefer not to place stent, but if there is a stricture, a real stricture, we place stent, 1 or 2. Most often we place 2 stents side by side in order not to have to do too many exchange. But the patient, for example, who have a stent and who are going very well when the stent is in place, then you remove the stent and they relapse pain, then they are very good candidate for the less invasive surgery, which is pancreatic jejunectomy. And so if we place a stent, usually we place 2 stents for 1 year with 1 exchange. At the end of 1 year, the patient was very much improved, but we remove the stent and the patient relapsed. I would be tempted, very often the patient doesn't want surgery, but if the patient accepts, I would be tempted to do surgery.
Good. Okay, I think we learned a lot. Our cliffhanger this time is that, Jacques, you have to come back for the no stone case, but we need pictures and images and the classifications, and because here it gets really complex, right?
Yes, this is complex because also the non-stone case, they bring the other differential diagnosis with malignancies and so on.
Yes. Okay, but for this session, thank you very much.
Thank you very much.